The ascending aorta is the last frontier of endovascular therapy. This is a very hostile anatomical territory for endovascular repair. The diameters are very large. The landing zone is very short. The lumen is non-cylindrical. There are massive compliance forces. And there's also significant interference with both cardiac output and respiratory motion. So because of this, the boundary conditions of the ascending aorta are a significant challenge. It has been a difficult area to design a specific device for. I want to ask my co-panelist, Dr. Khoynezhad, to tell us a little bit more about the endobental concept and how the first in-man procedure was recently performed.
Thank you very much. I totally agree that the ascending aorta is a very challenging location for placement of a stent graft. This is especially true if you're talking about endobental procedure, which endobental includes replacement of the aortic root that includes the valve, the coronary arteries, as well as the first portion of the aorta. And this is not only technically challenging, but as Dr. Azizzadeh alluded to, it is an area that requires significant changes in sort of the way we're thinking about stent grafting. We need different types of stent grafting, we need different materials, and we need a reliable way to perfuse the coronary arteries. Now, there are two concepts in endobental procedure or proximal aortic replacement. One is the endoVEITH, which includes replacement of the valve as well as the ascending aorta above the sinotubular junction. And the true endobental is really the one when you replace the valve, the aortic root, as well as the ascending. That means in the endobental, you have to actually revascularize the coronary arteries without having problem with endoleak, which is the key component and the Achilles tendon of endobental. Now, the first endobental procedure was performed as off-label procedure. Who would imagine, obviously, in Brazil, using devices that are currently not available in the US or in Europe. And it included really a torque abdominal branch device that had two branches for the coronary artery perfusion. Geomet stents, which are known and approved coronary stents, stent grafts, are used to connect those branches to the aortic coronary ostia. And a new type of balloon expandable valve was used to replace the aortic valve. Now, based upon the current registry, we know about 90% of the transcatheter valves will survive 5 to 10 years. The question is, does the material that we use in the aortic root for the endobental will last as long as well, given all the hemodynamic forces Dr. Azizzadeh alluded to? So I wanted to ask Dr. Azizzadeh what his thoughts about that.
As we've discussed, this is a significant challenge. I think the endobental would be the icing on the cake. I think there's more simpler, I would say, pathologies that we have to address first. I would say patients with type A aortic dissection who are non-operative candidates would probably be a easier first step before we get to the endobental. And then potentially patients who have complications of open aortic surgery, like pseudoaneurysms and residual dissections after a previous median sternotomy, would also be a step towards getting to the endobental. So perhaps it's worth talking a little bit about the early feasibility study that was just completed in the US. The ASG device is a device that was manufactured by Gore. It is the first device, to my knowledge, that has specifically been manufactured for this anatomy, and they just completed an early feasibility trial in the US with 19 patients, which was published. And I think that's a step towards having a dedicated device for the ascending aorta.
That's a significant step, and I know Dr. Azizzadeh was an active participant of this trial. Dr. White, my mentor and a partner at work in Los Angeles, we have had a PSID as well in the same direction, which we treated ascending aortic pathologies. We treated 4 patients, 3 of them with acute aortic dissection and 1 with intramural hematoma. And within those patients, 1 patient actually had the endoVEITH procedure that I alluded to. And we had a 7-year follow-up on these patients who recently expired from natural causes. So I think there's feasibility out there. There's the first clinical trial, as Dr. Azizzadeh alluded to. And this is an exciting area that we really wanted to proceed. I think type A dissection, as it was mentioned, is the low-hanging fruit because that's an area that the surgical mortality is at least 20%. And so we have a lot of chance to reduce the mortality in this patient population. And I think EndoVEITH would probably offer a treatment for 90% of the type A dissections once we have the proper devices. So very exciting field area. And again, we look forward to new development in this area.